All right, welcome guys to the sixth talk in the Neuro series. Today we're going to be talking about neuropathy. This is a talk that's geared at a slightly higher level. It's one of two talks, the other one being myopathy, that are more geared towards the basic physician trainees who are going to do their examinations later this year. But you should be able to follow along as a medical student. So, going back to our opathies chart, we spoke about encephalopathy last week. That's brain disorder. There's myelopathy, spinal cord disorder, radiculopathy, plexopathy, which are nerve root and plexus disorder respectively, and of course neuropathy, which is what we'll talk about today. And next week we'll talk about myopathy. Now the term neuropathy refers to any disease affecting one or more peripheral nerves. The diagnosis is always, of course, based on history and examination. This is where it's very useful to do a nerve conduction study plus or minus electromyography, EMG, so NCS EMG. And then we try to classify it using the clinical examination plus the NCS EMG. And we may need to do some bloods, shoot off some bloods and spinal fluid tests to work a little harder to figure out the etiology of the neuropathy. Sometimes we perform a nerve biopsy. This is very rare. Examination. The best examination in neurology, and I would argue in all of medicine, is the gait exam. The reason for this is that the gait exam gives you a huge amount of information very quickly, and it can allow you to just discard many other differentials and allow you to hone in on what the most likely list of differential diagnoses is. When you're analyzing the gait exam, the first step is inspection or observation, preferably in a hallway where they have some room to walk up and down. And really, when it comes to neurology, there are these 9 major gaits. There's not much more than this. When it comes to the examinations, it's going to be one of these 9, almost always. So something like an antalgic gait is not on here. That tends to be seen in an orthopedic context, not a neurological one. So what you want to do when you start your gait exam is just watch the person walk, and observation is the key, and you're trying to identify one of these 9 gaits. Now, the ones in yellow are the ones that a neuropathy might give you. The other ones, though, I'll just briefly talk about. So there's 2 that relate to the basal ganglia, the Parkinsonian gait and the choreic gait. The Parkinsonian gait, of course, small, shuffling steps. You might have other things, such as freezing. They stop mid-stride, and then they start going again. Or the patient might have hesitation, particularly when we try to get out of a chair. They hesitate before they get up. You might see festination, where the steps become quicker and shorter as they walk, and they might even need an object, such as a table or door, to actually stop walking or they'll fall. So that's often seen, of course, in Parkinson's disease. The choreic gait is characterized mainly by hyperkinetic movement disorder, namely chorea, which is these sort of random, semi-random flowing movements that go from one part of the body to the next. They often involve the small muscles of the face and hands first, and then they progress over time. Of course, that's mostly seen in Huntington's disease in New Zealand. Then there are 2 sort of upper motor neuron pyramidal tract damage gaits, hemiplegic gait and paraplegic gait. The hemiplegic gait is also known as a circumducting gait, where the upper limb is flexed and the lower limb is extended, and they swing the leg out because the lower limb is extended. It's a little longer because of the plantar flexion. You see this in a lot of disorders, particularly stroke and multiple sclerosis, which tend to involve one cerebral hemisphere predominantly. The paraplegic gait is kind of like the double version of that. So the paraplegic gait, they might have flexion in both upper limbs, extension in both lower limbs, such that they're actually standing on the balls of the feet. They might have to crouch a little bit because the center of gravity is off. You see that one in, it's also known as a spastic gait. It's very, it's somewhat synonymous with the spastic gait. And you see this one in things like cerebral palsy and hereditary spastic paraparesis, basically those 2 conditions. Then you have your 2 ataxic gaits. So the cerebellar ataxia and the sensory ataxia. The cerebellar ataxia, of course, is a cerebellar problem. The sensory ataxia is a proprioceptive problem. So the cerebellar ataxia will give you a wide-based veering gait. The sensory ataxia will also give you a wide-based veering gait, but will give you some extra stuff too. You might hear the person stomping. Possibly they're hitting the floor harder to try and augment the proprioceptive input to help them walk better. They might be using their eyes to compensate because their proprioceptors are damaged. Remember, with the sensory ataxia, it may not just be a neuropathy because there are proprioceptors in the brain and the spinal cord and the nerves. So that gait is a little more difficult to localize. A foot drop is where one foot, you have to raise the leg higher because the foot has trouble dorsiflexing. And it looks like they're dropping the foot. They might scuff the toes along the floor. They have to raise it higher in order to not trip over the foot. And that's often seen in a mononeuropathy. We'll go over that soon. And a steppage gait is basically a bilateral foot drop. And you see that in a few conditions, but particularly a more generalized neuropathic process. And of course, the myopathic gait, which we'll talk about next week, is a gait characterized by waddling. So the pelvis, when they lift up, because it usually affects the hips, makes the hip muscles weak. When they lift up a leg, normally your hips would stay parallel to the floor, but in someone with a myopathic gait, the pelvis will drop down on that side, and then when they lift the other leg, it'll drop, so they sort of get this waddle. And it's also known as a Trendelenburg gait. So there are 9 gaits. I just covered them very quickly because we're going to focus on neuropathy today. But if you know those 9 gaits, you can ace the gait exam because the observation part is 90% of it. That being said, there are 4 other steps. So step 2, it's always good to stand the patient with their feet together and ask them to do a heel-toe walk. So if they can stand with their feet together, it means they have reasonable balance, and if they can heel-toe walk, they have very good balance. Now, this step is basically focused on the ataxias. So does this person have ataxia or not? It doesn't differentiate between cerebellar and sensory. It just tells you whether there's ataxia or not. So they're non-specific tests of balance. But it could be a cerebellar or a sensory ataxia. Now, for any of the other gaits, of course, this test is a little bit superfluous, but we do it anyways just to be comprehensive in the Australia-New Zealand system. So the third one is where if you did see some ataxia, you saw an ataxic gait, then they had difficulty with, say, the heel-toe walk in step 2, then you want to see if it's cerebellar or proprioceptive. And we test Romberg's. You can do feet apart or feet together. I prefer feet apart, like in a normal stance, because some people, particularly the elderly, start to lose a bit of proprioception as they get older anyways. I don't see the point in making it too difficult for them. You know, if there's pathology there, then they'll have trouble with the feet apart with this test. So basically, you get them to close their eyes, and we say Romberg is negative if they can maintain the stance. So their proprioceptors are okay. They say you need 3 things, so proprioception, vision, and you need some kind of vestibular input in order to stay upright, and you can probably get by with 2 out of 3 functioning. So by closing the eyes, you remove one, and if, of course, they have a proprioceptive defect, then they've only got one left, vestibular, which is not enough, and they will sway and fall. So that would be a Romberg positive. Okay, so Romberg's is a test of not cerebellar function, proprioceptive function. Very important. The 4th step is to stand the person on their toes and then their heels. And what you're doing is testing distal strength. And this is very important for a neuropathy. Most generalized neuropathies affect strength distally. They give you distal weakness. So if they have difficulty standing on their toes, they might have weak ankle plantar flexion. And if they have difficulty standing on the heels, it suggests weak ankle dorsiflexion. And if that's the case with the second one, you probably should have seen a foot drop or steppage gait. 5th one is aimed at myopathy mainly. You get the person to squat comfortably. And if they have difficulty doing a squat, then you have to grade it for age and you know how much muscle mass they have and so on. But if they can't do that to a degree that you think they should be able to, it suggests proximal lower limb weakness, more commonly a myopathic process would be suspicious there. So that's the gait exam. The first step, identifying the gait, is really the most important by a mile. And if you can do that, then this is certainly the most important examination in neurology. Now, after the gait exam, you might do a lower limb exam. So again, it's just a few steps here. First, inspection, again. Inspection is usually the one that people do the poorest. They want to rush in and start doing stuff, but trust me, inspection is usually the most important one. Must check for two things in particular. There are many things you can look for in inspection, but two things in particular, if you don't actually consciously try to look for them, you will very likely miss them, and they are wasting and fasciculations. You want to look at the muscles and compare the left leg with the right leg, look proximal versus distal, and see if there's any wasting. And fasciculations, which are these tiny little spontaneous random twitches that you can see in the muscle. They reflect denervation. So muscles that have lost their nerve input, and they're common in neuropathic disorders. They're very easy to miss. So you have to basically look at this person's muscles for fasciculations for, they say a good 30 seconds. It's probably true. So if you see wasting in particular, have a very hard look for fasciculations. Now, tone is what I like to do next. Check tone at the knee and check tone at the ankle. And also a third thing is to look for this thing called clonus. This diagram is showing you how to test for clonus. Just bend the knee slightly with one hand and push in quickly with the other, dorsiflexing the foot as you do so. There's no need to use a violent motion or make these big circles that some people do beforehand. So it's a very quick thing, just in and if there's clonus, then you'll see it if you have a nice technique. It's quite technique dependent. If you don't do it well, you may miss it. So you really, non-sustained clonus is sort of 5 or 6 beats or less of the foot beating. You're really more interested in sustained clonus. That's highly suggestive of upper motor neuron pathology, where it just keeps beating away. Third step, I like to do power. Where people go wrong with this one is they try to do too much trees, not enough forest. So they try to remember all the different medical research council grades, 4, 3, and even worse, they use the pluses and minuses, 3 plus, 4 minus, 5 minus. It makes it really hard to remember everything that you did, particularly if you're being examined and you're a bit nervous. So rather than do that, focus on the overall pattern of weakness. Just determine, is the weakness yes or no? Good, okay. If there is a weakness, is it asymmetric or symmetric? Is it more on the left, more on the right, basically? Is it proximal or more distal? This is the important stuff. So don't lose the forest for the trees because, of course, distal versus proximal weakness, that's going to change what you're thinking. Distal would be more likely neuropathy, proximal more likely myopathy. There's overlap, right? But generally, this is what is useful in the power exam. Reflexes. Reflexes are quite technique dependent, so knee and ankle jerks. I would say two things. When you do these things, some people, when they're doing them, they bounce the hammer off the lower limb, and I think it's much better to just let it drop, mainly with just the weight of the hammer itself and using gravity. Sometimes you need to give it a little more oomph, but not much. And the other thing, when you check the plantar responses, because they are a reflex as well, a very good one, abnormal plantar is a very powerful sign. So remember, downgoing is normal in an adult, upgoing is abnormal. I always warn the patient it's going to be a tickle rather than a scratch, and often it is a tickle. It shouldn't be a scratch. A scratch probably means you're pushing too hard, and you shouldn't be leaving big gouge marks in the person's foot. So just a tickle, you don't need to do it much. Quite technique dependent, and I'll show you how to do them. Should you do a neurology rotation, or should we be doing an examination together? Coordination is next. So this is basically the best test for this is the heel shin test, which would be quite possibly normal in a sensory ataxia, so a proprioceptive base neuropathy or whatnot. And I think the most important thing is, of course, you ask the person to put one leg, the heel of the leg, up on the knee and then slide it up and down the shin bone. And you must tell them, please be accurate, because if you're not told, they're not told that, a patient might just sort of go, oh yeah, and it might look like they have some irregularity of movement or ataxia when in fact they don't. Sensation I leave to the end. So there's 6 steps to lower limb exam. Same with the upper limb exam. Sensation I leave to the end for a very good reason. Don't put too much credence in your sensory findings. They are, unless they're very strong, because it can often mislead you. A patient might say, oh, that one feels a little lighter, and then that one feels a little more, and it can make things very difficult. Basically, the rule of sensation, when you do the sensation exam, is you should already know what you're looking for by that point in time. So you've done the rest of the exam. It's like, okay, I think it's a spinal cord disorder, so I think there should be a spinal level. Okay, I think this is a neuropathy, so I think there should be distal reduction in sensation, maybe up to the heel or up to the ankle or shin or knee or something. So you must know what you're looking for with sensation. Otherwise, it's very difficult. Now, always check light touch. When it comes to pinprick and temperature, they're both testing the same thing, more or less. Okay, so they're testing the small nerve fibers in the peripheral nervous system, and in the lower motor neurons, and in the upper motor neurons, they're both testing the spinal thalamic tracts. So pick one, pinprick or temp. There's no need to do both. If you had to choose an exam setting, pinprick. If you want the quicker and easier one, temperature. And same with proprioception and vibration. They're testing the same thing. So in the peripheral nerves, it's the large nerve fibers rather than the small ones. And so that's the lower motor neuron, the lower peripheral nerves. And in the upper motor neurons system, or the sort of brain and spinal cord, then of course it's the dorsal columns in the spinal cord. So you can pick one or the other. You don't have to do both. And I choose proprioception here because proprioception is generally, proprioception starting with the big toe. That generally should be intact in anyone regardless of age, whereas vibration can start to diminish in elderly people. I find it less useful. And it takes a bit more time, I think, to do it properly. So if you're doing an exam, pinprick, proprioception are probably the two that I would do. If you're on the wards, temperature, proprioception, I must admit, I do those two quite a bit. So again, don't linger on sensation unless you know exactly what you're looking for. If you don't know what you're looking for, then really just do it and keep going. Okay, nerve studies. Not a lot of people learn about nerve studies unless they actually become neurologists. So they're quite straightforward. You stimulate the nerve at one site. This elicits an action potential from a neuron, or a group of neurons, I should say. And then you record those action potentials at a distant point. And there's really only 3 major parameters. So we talked about SNAPs and CMAPs. SNAP is sensory nerve action potential, and CMAP is compound muscle action potential, or compound motor action potential, rather. So you want to look at amplitude. The amplitude of the action potential basically tells you how many axons are there and functioning. So it's a measure of axon integrity. The second variable is latency. It's a measure of time. So that's the blue arrow. And basically, it's the time taken for the action potential. We use the peak or the onset, depending on whether we're looking at a SNAP or a CMAP, to appear at the recording electrode. That measures the integrity of your myelin, the insulation around the neurons, around the axons. And then there's velocity. So velocity is quite straightforward because once you have amplitude, once you have latency and you measure the distance with a tape measure, then you just do your V equals D over T formula and you get velocity. And that's another measure of myelin integrity. So latency and velocity basically correlate. If they're both out, they'll both agree. Okay, so really the main purpose of nerve conduction studies in a neuropathy is to figure out if there's a neuropathy, first of all, and if there is axonal or demyelinating. Are axons being lost, or is myelin being lost and the axons are spared? And sometimes you can get both. But in an axonal neuropathy, of course, the amplitude will be decreased, which indicates axon loss, whereas the latency and velocity will be preserved, so the myelin is more or less okay. In a demyelinating neuropathy, the amplitude is preserved, so the peak will be pretty good, but the latency is prolonged and the velocity is decreased, indicative of demyelination. Why is that important? Because axonal and demyelinating neuropathies often have very different treatments. Demyelinating neuropathies are often immune-based and related to an infection. So whereas axonals have a multitude of different etiologies, and so the treatment will vary depending on which one it is. Okay, so it's very helpful for classifying and diagnosing the neuropathy. And once you classify and diagnose the neuropathy, of course, the treatment is fairly straightforward. It's like encephalopathy. Neuropathy has a lot of different etiologies. It's really finding that diagnosis is the key, because once you find it, then treatment is usually fairly straightforward. You can look it up. Okay, electromyography, or EMG, is the other half of the nerve conduction and muscle study testing. So this looks at abnormalities that may be presented by nerves or muscles or nerve roots, the radiculopathies. So we look at three things with EMG. You stick a needle into muscle, any muscle really, and now you're measuring the muscle action potentials. So of all the little muscle fibers in the vicinity of the needle. Now, if it's normal muscle with lots of, all the muscles have nerves attached to them, the muscle will remain silent after you insert the needle. If some of the muscle cells are still, are denervated, they will spontaneously contract and twitch, and you'll get these things called fibrillations and sharp waves. So that's a single muscle cell that's twitching away, and it'll look like that little picture there. Fib means fibrillation, PSW means positive sharp wave. They're the same thing, except PSWs are deflected downwards. Fasciculations indicate denervation of basically the muscle supply by a whole motor unit. So it'll be much bigger on the EMG, and of course you can actually see those clinically. You can't see the fibs and sharp waves by looking at a muscle with your eyes, but you can see the fasciculations. But they all indicate the same thing, denervation that's ongoing. Next, you look at recruitment. So recruitment is where you get the person to give you sort of 25% full power, 50% full power. And as they do that, you want to see how well, as you do that, you recruit more muscle units to help against whatever it is that the muscle's contracting against. And with a neuropathy, you see reduced recruitment. What you see is, because in neuropathy, some of the nerves, motor nerves in particular, are damaged. The ones that remain grow out to compensate and become bigger, but there's fewer of them. So you get this bottom picture where you get these bigger, higher amplitude waveforms, but there's fewer of them. You can see the individual ones. Myopathy is the opposite. So myopathy, you've got weak muscle cells. Nerves are more or less okay, but you have to recruit a heck of a lot more muscle cells because they're weak. And so you actually get rapid recruitment or early recruitment. So a lot of muscle cells have to get brought in to do the motion right away. So it looks very different. You get all these tiny little waveforms. I'm trying to cover basically a year of training in one slide here. There's quite a lot to EMG. And the third step here is the morphology. So we look at the shape of the motor units. So these ones here are, that I'm showing on the bottom, are large amplitude, long duration, polyphasic, many phases crossing the midline. That's suggestive of neuropathy. It just means there are only a few but very big nerve fibers there, motor neurons, innervating lots of different muscle fibers. Whereas the top one there would be something you'd see in like a myopathy, where, again, you've got lots of smaller units, and the nerves are okay. Okay, so that's a whirlwind for nerve studies EMG, and that's absolutely the extent of it you need to know, even for the basic physician trainees doing their exams. This is a very important slide, classifying the neuropathy. So you have some kind of neuropathy, and it's going to be either a mononeuropathy, which is due to compression or trauma, or it'll be this thing called a mononeuropathy multiplex, which is axonal or demyelinating, or it'll be a polyneuropathy, which is acute chronic axonal or chronic demyelinating. This is what I find to be the best way to classify them. You'll see variations on this in books. Now, basically with mononeuropathy, there are 4 of them, and it's really good to know them. They're extremely common, and we all know people with at least most of these, I'd say. The mononeuropathy multiplexes are not that common, but they are very important to pick out because they need to be treated in general. They can be very nasty. So they tend to be subacute. They come on over days or weeks, maybe months. Asymmetric, so they'll involve, say, one leg or one arm more initially. They can be sensory or motor or sensory motor, so sensory nerve, motor nerve, or both. And they can be axonal or demyelinating. The polyneuropathies, poly means basically they're generalized, so nerves all over the body, often appear in the lower limbs first. They're symmetrical. And again, they can be sensory motor and axonal or demyelinating. We're just going to go through the most common and most sinister of these ones, the ones you really need to pick out with patients on the ward or in the outpatient clinic. So again, if you can classify the neuropathy, the diagnosis is right around the corner. And the way we describe a neuropathy, basically we describe is it a mononeuropathy or is it a generalized one? Mononeuropathy multiplex and polyneuropathy tend to be generalized. Is it symmetric or asymmetric? Mononeuropathy multiplex tends to be asymmetric, polyneuropathy symmetric. Is it sensory motor or sensory motor? And is it axonal or demyelinating? Of course, you need the nerve conduction study to figure out the last one. You can't tell if it's axonal or demyelinating on the exam. Mononeuropathy. Okay, so this is just a focal compression of a single peripheral nerve. The four that I mentioned that are super common are median neuropathy at the wrist, also known as carpal tunnel syndrome. It's the most common. There's ulnar neuropathy at or near the elbow, which is also known as cubital tunnel syndrome. There's a radial neuropathy, which is usually at this place called the spiral groove. If you look up your anatomy of the upper limb, it'll give you a wrist drop clinically. And then there's a peroneal neuropathy at the fibular neck, which gives you the foot drop. Some people present with mononeuropathy secondary to a trauma. All bets are off. Trauma can damage any nerve in any weird location. Okay, so the ones on the left are far more common with trauma. When we get when Josh or Gloria our technicians get a trauma-related neuropathy, it can be quite a difficult study. Okay, so carpal tunnel syndrome. If it's fairly severe, will look like this. You'll get this thing called an ape hand. That's a misnomer because apes actually have opposable thumbs, but what the patient does is they lose their opposable thumb function. And you can see there I've circled the thumb, and then there's a black arrow pointing to the abductor pollicis brevis muscle. They're saying thenar atrophy, so it's quite atrophied. And because that muscle abducts the thumb, they've lost that, and that is very useful for opposable thumb action. They kind of lose that. So you get wasting and weakness. Again, I've circled the APB muscle, and that's very distinctive for carpal tunnel syndrome. Sensory-wise, this is the pattern. The blue is the deficit. Now, it's very important to note that you have a loss of sensation in, yes, the thumb, index finger, and middle finger, so those three, but it's only 1/2 of the ring finger, not the whole ring finger. That's very important because the main mimic for carpal tunnel syndrome is a C6-7 radiculopathy. That's a problem up in the cervical spine, compressing the C6 and 7 nerves. And they have a dermatonal pattern of sensation, right? So when you talk about dermatomes, you're talking about nerve roots, not median nerve, peripheral nerve. But in a C6 is you think of I learned it as a C6 shooter, a gun. So it does sensation for the thumb and the index finger. C7 does the middle finger, but they don't do the ring finger, either of them. That's C8. So if the ring finger is completely spared, it's probably not carpal tunnel. Carpal tunnel should involve half the ring finger. It's very useful. Ulnar neuropathy at the elbow. We see this one a lot too when we do nerve studies. So this will classically give you a claw hand, which is the ring and little finger. So they'll be a little extended at the metacarpophalangeal joints, and the IP joints, the interphalangeal joints, will be flexed, just as shown in the picture. So you just get this sort of claw. Now, the ulnar nerve innervates the interossei on the dorsum of the hand. That often seems counterintuitive. When I was a med student, I didn't understand that, but trust me, it does. And so the best muscle to look at here is this one right here, first dorsal interosseous, the big one between the thumb and the index finger. That will be wasted. And you can look at the hypothenar muscles both on the other side of the hand. So this is the thenar side of the hand, the thumb, and the hypothenar is the other side of the hand. And you look at abductor digiti minimi, which is the little finger. And you can see there on the left where the white arrows are pointing that the muscle is atrophied. It looks like it's scalloped out. You can look for these other signs, which you do actually see quite often if you look for them. Fromage sign. So again, what they do, their flexor pollicis longus, which flexes the thumb, it's okay, but they can't really their interossei are messed up because it's an ulnar neuropathy, so they can't really do that with the thumb, so they compensate by using the flexion more to grab things. That's a Fromm's sign. And then there's a Wartenberg sign, which is, again, weakness of the, the interossei means they can't really bring that pinky in. So there's another muscle that brings the pinky out, and it's unopposed. So the pinky will be sticking out, and it gets annoying if they try to put their hand in their pocket. They might complain that my pinky keeps getting, stuck on things. The sensory loss pattern is, again, the other half of the ring finger and the little finger in totality. So the rest of the fingers in hand, rest of the fingers, I should say, that are not median innervated. The main mimic for this is a C8 radiculopathy. In that case, you get, again, like I said, sensory loss in the entire ring finger and little finger. Radial neuropathy at the spiral groove. Now, it's usually at the spiral groove, and it gives you a wrist drop. This brachioradialis muscle here, which flexes the elbow when the arm is in a sort of semi-pronated position, that is also wasted if the radial nerve is damaged at the spiral groove. So it's quite distinctive, this muscle. If you activate it properly, it pops right out. This will give you sensory loss over the lateral dorsum of the hand, exactly that pattern in the red. Now, the mimics for this one are radial neuropathies at other parts of the radial nerve. So if you have one way high up near the neck, so like in the axilla, which is near the armpit, then you'll get a involvement of triceps, because the radial nerve actually innervates triceps, so that will be wasted as well. If it's way far down, and there's a branch off the radial nerve called the posterior interosseous nerve, then you might spare brachioradialis, so that muscle there will be normal, and you won't have sensory loss. You'll just get the wrist drop and not a lot else. So clinically, you can determine often not only is this a radial neuropathy, but to an extent where the damage is. And then you can tell the person doing the nerve conduction study what they're going to find, hopefully. So peroneal neuropathy at the fibular neck, foot drop. This is the most common cause of a foot drop. And honestly, the best clinical sign if a person has a good foot drop is they have a foot prosthesis like this. So it's kind of an obvious one. If you see this, almost certainly they have a foot drop. This will give you, this is often associated with wasting weakness of tibialis anterior, which is the muscle sort of at your shin, near your shin, that dorsiflexes the ankle. And also you get weakness of eversion. The everters, which I've listed there, are also weak. If it's a foot drop from a peroneal neuropathy at the fibular neck, and that's almost always where it is, at the fibular neck, just below the knee, then inversion and plantar flexion are going to be okay. This is the pattern of sensory loss, the green bit. It's just good to know it. Now, if you get a foot drop, it's good examination because your lower limb exam will probably help you figure out which of 5 things it is. It's almost always just going to be one of 5 things. So, of course, a common peroneal neuropathy at the fibular neck is the most common. Number 2, though, which is probably not close behind, is an L5 radiculopathy. So it's a nerve root problem, very different location, right? Up near the lumbosacral spinal area. So that will give you weak ankle dorsiflexion, eversion, and inversion will be weak because L5 inverts. So that's very useful to distinguish it from the first one. A sciatic neuropathy can give you a foot drop. In that case, the sciatic nerve will also involve weakness of plantar flexion. Motor neuron disease, particularly the ALS variant, amyotrophic lateral sclerosis, which is the most common form of motor neuron disease. That can give you a foot drop with any sort of combination that I've mentioned, but you're going to find upper and lower motor neuron signs when you do your reflexes and the rest of the exam. And the last possibility is a brain or spinal cord lesion, and of course that will give you only upper motor neuron signs. So this is how you tell between the 5 things. If you get a foot drop, it's one of 5 things, and you just got to go through it logically, and you can figure it out. Okay. Mononeuropathy multiplex is very easy. If you understand mononeuropathy, you understand mononeuropathy multiplex. It just means 2 or more mononeuropathies. That's it. So because it's 2 or more mononeuropathies, like a left peroneal and maybe a right tibial or a right median neuropathy, and they're related, the processes are related that cause them, then that's a mononeuropathy multiplex. And of course, it'll usually be almost always asymmetric. This is the best way I think of them. So axonal or demyelinating. Now, axonal ones are going to be vasculitis or infiltrative. Axonal mononeuropathy multiplex is nasty. We must get onto that. We must diagnose it reasonably quickly and treat it, because vasculitises involve nerve death at a fairly rapid rate, and they can be primary or due to a connective tissue disease such as rheumatoid arthritis, lupus, or Sjogren's. So there may be a systemic disorder you need to treat as well. And infiltrative things, tumors, of course, amyloidosis, sarcoidosis, lymphoma, and so on, those need to be diagnosed pretty quickly too. So there are rare etiologies, but if you find a mononeuropathy multiplex and it's axonal on the nerve conduction study, really need to get onto that. Rarely a mononeuropathy multiplex will be demyelinating. One great mimic of motor neuron disease is called multifocal motor neuropathy plus or minus conduction block. So we'll talk about that one briefly. The one circled I'll dedicate a slide to. There's a couple of others there. So HN-LPP, which is hereditary neuropathy with liability to pressure palsies. We do see that sometimes. And then chronic CIDP MADSAM is a variant of CIDP, which means chronic inflammatory demyelinating polyneuropathy. And there are a few variants of that. We're going to talk about them when we do the polyneuropathies in a few slides. So, okay, so again, these are subacute, generalized, asymmetric. They can be sensory motor, and axonal or demyelinating. So before you know what the etiology of a neuropathy, you describe it. It's like if it was a mononeuropathy multiplex, you'd call it a generalized, asymmetric, axonal, sensory motor axonal neuropathy, something like that. If that's what you found clinically and on the nerve study. Okay, so vasculitic neuropathies are nasty. They're subacute, they're painful, and they're predominantly motor neuropathies, and you get inflammatory destruction of the nerve blood vessels, followed by ischemia and infarction of the nerve if you don't treat it. So the person will get an asymmetric axonal neuropathy. Usually the lower limbs are hit harder, and it likes to go for the peroneal nerve. Multifocal motor neuropathy is a pure motor neuropathy. This is a mimic of motor neuron disease. It's often stepwise, so it won't be progressive so much as it occurs in steps. And it's associated with a thing called anti-GM1 antibodies, which is found in the majority of patients. You can check for those. Now, it is asymmetric motor demyelinating, okay? And it, in contrast to vasculitic neuropathy, often goes for the upper limbs, and it likes the ulnar nerve. Now, how do you tell between this and motor neuron disease? Because they look very similar. Well, it generally shows a lot of fasciculations and not as much wasting as motor neuron disease. And it usually lacks bulbar, so sort of swallowing muscles and speech. They're generally not affected in this, whereas in motor neuron disease, those things are commonly affected. And it doesn't hit respiration usually, whereas in motor neuron disease, respiration can be affected too. One of the best things, though, if you're doing an examination, motor neuron disease will very frequently present with this thing called a split hand syndrome, which is what I've shown you here. So split hand syndrome is where you get wasting of the thinner side of the hand, the thumb, muscles near the thumb, okay, particularly the first dorsal interosseous on the dorsum, and on the other side, the abductor pulsus brevis. But this part of the hand, the hypothenar part, is okay. Now, if it was a median neuropathy, then you should have sort of more wasting than just APB. You should have some wasting over here. And if it's ulnar, you should have wasting across the whole thing. So if you're only getting wasting of this muscle but not this one, it means it's probably not ulnar. And it's probably a split hand. So you've got a split. This part of the hand, the thinner part, is wasted, and this part is not. A split hand is very specific for motor neuron disease. And so if you see that, you think motor neuron disease rather than multifocal motor neuropathy or anything else. Seeing a split hand on examination is great because automatically you can be quite confident that you've got a motor neuron disease as a diagnosis. Okay, so the third kind of neuropathy is the polyneuropathy, symmetric distal length dependent. This is the one that most people learn about I suspect, the most, because it's very common. So I divide these into acute pathologies, Guillain-Barré syndrome in particular, which is an umbrella term itself for a number of variants, AIDP, Miller-Fisher, AMAN, MSAM. We don't need to go over those, but just know that Guillain-Barré is an umbrella term with many variants of its own. And there are other rare etiologies. So if someone gets a polyneuropathy, which is a generalized symmetric neuropathy, and it's coming on quickly, like over hours or days, you go to that left box, not the right two. But most of these neuropathies are chronic. Now, the most common neuropathy in New Zealand is a diabetic neuropathy, which is a chronic axonal neuropathy. Number 2 is probably alcohol. And then there's a few other differentials there in red that I've put. There's quite a few differentials for a generalized axonal polyneuropathy. Demyelinating neuropathies also exist. So there's a fairly common one called the CIDP, chronic inflammatory demyelinating polyneuropathy, which has several variants. And we'll go over that one. There are paraproteinemic neuropathies, neuropathies associated with a paraprotein, an abnormal immune system protein and antibody or something like that, which gives you these demyelinating neuropathies. And then CMT means Charcot-Marie-Tooth. Charcot-Marie-Tooth is a hereditary demyelinating polyneuropathy, also reasonably common. So these are chronic, generalized, and symmetric. The diabetic polyneuropathy usually starts distally in the feet, involves the hands later. It's sensory first, motor later. There's often a coexisting autonomic neuropathy because it likes to go for the small nerves first. So, and the autonomic nerves are small nerves. So you might have postural blood pressure drops when the person stands up and so on. Diabetes can give you almost any kind of neuropathy. So there's one in particular that's good to know about, a proximal diabetic neuropathy, which is also known as diabetic amyotrophy. And it involves, it's also known as a radiculoplexopathy. It actually hits a bit of the nerve root and the plexus too. So it presents with an asymmetric proximal lower limb pain and weakness. And it usually goes for one leg first. And then the other one might be involved, days, weeks later. However, all of the 4 compression mononeuropathies, they're more common in people with diabetes. Pure autonomic neuropathies are common in people with diabetes, and pure cranial neuropathies, like say a third nerve palsy, are common in people with diabetes. So diabetes makes all of these neuropathies more common. CIDP. Now, CIDP is basically, it's not quite correct to say this, but we often think of it as the more chronic version of Guillain-Barré. So Guillain-Barré usually gets worse at around week 2, week 3, week 4, and then it improves, even without treatment very often. Whereas CIDP is different. It persists much longer. CIDP, Guillain-Barré tends to be a one-off. CIDP needs ongoing treatment. Now, it's generalized and symmetric and sensory motor and demyelinating, but it often goes, it's a little weird for a neuropathy because it likes to go and give a person proximal weakness and distal weakness. And motor nerves are affected more than sensory. So it's a bit distinctive in that sense clinically. One of the greatest things is these people virtually always lose their reflexes fairly quickly. They can present with a cranial neuropathy as well. It's not that common, but it is seen enough. Now there are variants. That's classic CIDP, what I just mentioned there. There's a couple variants that are quite important. They pop up once in a while. There's one called MADSAM, CIDP MADSAM, which is an asymmetric version of CIDP. And you get the arms, particularly the hands, involved first. The person will complain of weak grip. Another one is the CIDP MGUS. It's the same as the classic CIDP, but you get a paraprotein, IgG or IgA usually, and you treat it the same. So, but it does mean you might have to look for hematological disorders as well. Okay, I hope you're understanding it. Neuropathy is quite a complex topic, and I'm just trying to make it as simple as I can, but even then it's not easy. So Charcot-Marie-Tooth. This is a hereditary neuropathy. Usually presents in children or young adults, sometimes later in life. And there's several different mutations. So CMT1 is the most common. You get this duplication of a PMP22 gene. That's the majority of those people. You can get CMT2, CMTX. There's other CMTs as well. But they're all pretty similar clinically. Generalized symmetric sensorimotor demyelinating neuropathy. So this is distinctive. If you see a pes cavus, which is basically a high arch, and these hammer toes, you see how the toes, the little ones in particular, are pointing down like hammers? That is, if you're in an exam and you see that, again, inspection's everything, right? Inspection's the most important step. You're just like, okay, well, that is almost certainly going to be a Charcot-Marie-Tooth. And then the rest of the exam, hopefully, is fairly straightforward. You can look for these things, stork legs. So they have a disproportionate wasting in the distal muscles. The calves are quite thin compared to the quads and hamstrings. And they might have kyphoscoliosis. Ankle reflexes are usually gone or severely diminished, whereas knee jerks will be present. They might be diminished, but they'll be more elicitable than the ankle jerks. Okay, so neuropathy. Yes, we order blood and spinal fluid tests. I hope you can appreciate, though, that most of the diagnosis is, of course, history examination and the nerve studies EMG. The nerve studies EMG, I don't think of them as a test. I think of them as an extension of the clinical examination, because really that's what they are. You're actually extending your ability to do a clinical examination with them. So here are the tests. This is what I would do if you have a neuropathy. If you, as a neurologist, these are the tests I do. So you can just copy this down and send it on the forms, and away you go. So I do a complete blood count, electrolytes. I look at renal function. I look at inflammatory markers, CRP, HbA1c, diabetes, most common. It's very commonly involved in all of these neuropathies. Liver functions, thyroid levels. I check these vitamins in particular. B1 particularly, that's thiamine, particularly if there's a history of alcohol. Again, alcoholic neuropathy, second most common. Polyneuropathy. B12, serum protein electrophoresis, and the serum immunoglobulins. Now, that's the screening test I do for pretty much any generalized neuropathy. If it's plain old carpal tunnel syndrome, I won't do those bloods. I mean, usually that's pretty straightforward. Same with the ulnar neuropathy and so on. Now, if you have a generalized neuropathy and you're thinking, oh, clinically it could be vasculitic or infiltrative or one of these other things, these are the tests you order to more specifically pinpoint that. I would not order these tests unless there's a clinical indication. But if there's a clinical indication, by all means, do it. Okay? So I won't go through them. The list is there. Nerve biopsy, I've just got one slide dedicated to this. These should not be ordered lightly. So that's where you take a surgeon takes a sample of nerve and a pathologist looks at it. And by looking at the appearance of the nerve, you can do a series of tests and stains and so on to see figure out the etiology. They're rarely necessary. You rarely need to go to these lengths. And they can produce long-standing adverse effects. Most people, of course, they do a sensory nerve usually because they don't want to make someone weak. But if you take part of a sensory nerve, numbness is an obvious side effect, right? And some of these people experience ongoing pain even. So that's why you don't order them lightly. It's good to order these if you suspect a nasty neuropathy, such as a vasculitic or infiltrative one, and all of the other tests are inconclusive, and you really need to know how to treat this person, and you don't know how to treat them because you haven't diagnosed it. So in that case, it's appropriate. We had a patient in ICU, a young woman who we couldn't figure out which of these it was, and we did a nerve biopsy on her about a month ago, or 2 months ago, yeah, wasn't it? Yeah. Okay, so you can order these, but it's good to discuss with your colleagues before you do this. Okay, neuropathy. So remember, I hope you appreciate that the gait is the most powerful examination in neurology. The lower limb exam is also very good, particularly in neuropathy. Nerve conduction studies, the main benefit is to tell you if that generalized neuropathy is axonal or demyelinating. Okay, they're very good for diagnosing the mononeuropathies, absolutely, but they really shine in terms of telling us if it's axonal or demyelinating generalized neuropathy, because that will change our thought process on the diagnostics and the treatment. And EMG is also very useful. The EMG will show large amplitude, long duration polyphasic units. So if you're asked in examination, if you think you have a generalized, axonal neuropathy secondary to diabetes or something, and they ask you what's going to be shown on the nerve conduction study, just say, oh, I think it'll be an axonal pattern. That's it. And then on the EMG, well, they'll have large amplitude, long duration, polyphasic units. That's done. Okay, so, and I'll tell you what to say for myopathy on the next week's talk. It's equally easy. So know the 4 mononeuropathies, cold, carpal tunnel syndrome in particular, very common, very easy to identify. Remember, all mononeuropathy multiplexes start out as a mononeuropathy. So you get a weird mononeuropathy, that's come on quite quickly. Be very wary, this could be a mononeuropathy multiplex. And finally, so important to classify these things correctly. So classify them as mononeuropathy or generalized. If it's generalized, there's 3 things. You call it asymmetric or symmetric. You call it sensory motor or sensory motor. You call it axonal or demyelinating. You need neurostudies for the last. So you describe a neuropathy before you know what it is as a generalized, symmetric, sensory motor, axonal neuropathy, if that was the case. So it's like Lego. You put those terms together, and that gives you the power, because once you can classify it like that, the differential, you just use the charts that I gave you, a few blood tests, and you're good to go. You'll figure it out. Thank you.